everybody. And speaking of resources, I did wanted to remind everybody that we are, September is our Suicide Prevention Month. And so I just wanted to let everybody know that there'll be lots of activities around the community regarding suicide prevention and resources. To remind you all, our national access to suicide resources is our 988 number, and you can call that from your own personal phone or cell. They'll track your originating area code to match up with a resource here in Hawaii. Just was told by Dr. Humphrey, who is the medical director for Child and Adolescent Mental Health Services, that they are redesigning their website for families and providers to access applications for families and children who you think might need resources, especially if in the clinic you're screening them for depression or other disorders, and then you can work with the family to get those applications done right there online in the office. And I was told that you'll get confirmation or feedback from somebody once you submit that application pretty fast.
Susan Wada says it is now live.
Oh, excellent. That's great news. Thank you for that update. And some other resources for our children and families. The American Academy of Pediatrics developed their guidelines for adolescent depression, and it's a toolkit, and that's online from American Academy of Pediatrics. That was published and provided in 2018, and that will be, I'll also put the access to that in our resources for today's presentation, because folks will tend to want to look at that and look at some of the screening they've used. Also, a little bit more detailed discussion on psychotherapies for both families and children, as well as some of the newer medications that are in the FDA pipeline. The medications that I shared today, even though this presentation was developed in 2000 and maybe 15, 16, there are other medications in the pipeline, but nothing quite FDA approved yet for children. So we'll talk a little bit about that. And also as a urgent resource, we talked about CAMHD for families and children needing additional mental health resources, especially those who you've screened in your offices. But Crisis Mobile Outreach, which is part of the Child and Family Services, which is a statewide access number for emergent services. And they have somebody on every island across the state, and they will respond to your call and even provide either office assessment or home assessment wherever the family and youth might be. So I'll make sure I have those numbers for you. Dr. Humphrey reminded us that even though it's affiliated with Child and Family Services, much of the funding and maybe all of the funding for that comes from CAMHD, and it's available for all families in Hawaii. Okay, so those are my announcements. Any thoughts, questions? Summer, just let me know if things come. I will address them as we go. I'll share my screen and start. And we'll do that. And get my. So today I'm going to present treatment of depression in children and adolescents. This is from our colleague, Sandra Stock. She is the program director of child and adolescent psychiatry at the University of South Florida. She's also part of the American Academy of Child and Adolescent Psychiatry, their committee that just updated the practice parameters for treating children and adolescents for depression, and their updated guidelines. I think 2016, she participated in developing those, as well as participated in the American Academy of Pediatrics in the resource that I just had mentioned, the GLAD, the Guidelines for Adolescent Depression and for Primary Care, and that's a toolkit that was developed in 2018. So some of the things, Michelle, I'm sorry, Summer, please let me know if you can't see this at any time, okay? Or if you can't hear me. So some of the learning objectives for today, to recognize symptoms of major depressive episode, kind of the typical course of depression, and interventions for depression based on symptom severity, and also supportive strategies that can be done in the primary care office, and also to be familiar with 4 medications to treat depression in youth, and understanding the risk of suicide with medication treatment for depression. We'll kind of talk a little bit about suicide throughout, and then also the role of medications in heightening our awareness of monitoring for suicide, especially with the black box warning for the SSRIs, or the selective serotonin reuptake inhibitors, which are the primary medications used and to start with for the treatment of children with depression. Some of the epidemiology, quite a few, it's affecting our youth. In regards to the pandemic with COVID-19, I have seen some of the numbers recently regarding the changes in these numbers, and they're a little staggering of the increase and how challenging it is for our children and our youth and our families to adapt to the pandemic stressors, both at home regarding the significant amount of time in isolation, and then now, the reintegration, which we've all seen in the past year or so, of children of reintegrating back into the school environment. But along with that comes the reintegration of quite a bit of social tension and social pressures and academic pressures that we're seeing cause quite a bit of stress for the families and the kids. So children, boys to girls, 1-to-1 in regarding their presentation of depression. But by the time we reach adolescence, the distribution is maybe 2 girls to 1 boy. So a little bit more with our girls. Greater than 50%, almost 80% are experiencing suicidal thoughts. And another staggering number, approximately 35 of our depressed youth will attempt suicide. And depression affects every facet of life, including the relationship with their family and friends, as well as their school development and performance and general health. And so as I talk about this, I will try to integrate much of what we do in Hawaii, and we tend not to treat youth depression in a silo. Historically, we did that, I think, in clinics, and physicians would treat with medication. But I think now we're seeing the evidence so strong for collaborative care, for integrating care, not only with primary care providers, but also within the schools, and also with child welfare services and family court, and making sure that all facets of that child's life is integrated in communication, care, and follow. Some symptoms to be thinking about with children when we're looking across the spectrum of mood and behavior, neurovegetative symptoms, and cognition. In mood, you may see irritability and depression, even lability of mood. Children may not be able to, especially younger children, may not be able to verbalize sadness, but they may demonstrate low frustration tolerance. They may withdraw from family and siblings, activities, and peers. They may talk about stomach problems or headaches, stomach aches that may be reflective of their mood. They may express interest in lots of or decreased interest in activities in sports. They may complain a lot about being bored. Neurovegetative symptoms that we see with children is fatigue or loss of energy, lots of disturbance in sleep, weight changes, appetite changes, psychomotor agitation, or retardation. We all remember Dr. Patel and Dr. Shipley talking about disruption in sleep in our families and kids who present with psychiatric illnesses. We'll have a follow-up next week looking at the role of obstructive sleep apnea and its involvement in psychiatric illness. Also, cognitive changes, feeling worthless, hopeless, have inappropriate guilt, and of course, thoughts of suicide. There are criteria that we look at. The SIGI CAPS looks at all the things we just talked about, everything from sleep to suicidal thoughts. Symptoms that we see that based on age. So at all ages, the depressed mood, all patients may describe it as, I don't care, I'm bored, I'm challenged with concentration, challenges with sleep, and suicidal thoughts. Children are probably more inclined to talk about stomach aches, headaches. You may see them experiencing significant stress or anxiety regarding separation from a caregiver or an attachment figure. This is pretty challenging when maybe the youth is involved with child welfare services, and they may have experienced separation from a primary caregiver multiple times over the most recent few years. Children may experience psychomotor agitation, specific fears, and they may even describe experiences of hallucinations, which is also very common with our children who have been involved in stress or trauma, and then who also have a comorbid depression. Teens describe anhedonia and hopelessness. You may see them involved in more self-destructive, impulsive behavior such as drug use, sexual behavior that's causing problems, and or access to injury or infection. Let me see if I can do this. Oh yeah. So this next section is, when do we start seeing depression? John Bowlby in his development series of attachment described, infants who were separated from a caregiver, describing the behavioral associations with depression, especially for the institutionalized infants. There were problems with sleep and feeding, listlessness, and being withdrawn. Depression in children and adolescents is usually the same illnesses that we see through transition into adults. But again, the recent studies that we're seeing are that even though the illness is continuous with adult, high relapse rates in adulthood we're seeing with those who've experienced their first episode of depression during childhood. And that's also a significant area of monitoring and treatment. When assessing the youth, as I spoke to just a moment ago, that we're no longer treating our families and children kind of in the silos of our offices or of our health centers. We're really trying to assess and interview the family in the context of the family, the parents, the youth, and also their involvement with school and their social activities, trying to get a sense of how that youth is doing in all areas, in all of their constellation of activities. Parents are better reporting behavioral disturbances, the time course of symptoms. Parents are definitely, especially for younger children, definitely able to get a better idea of trials of medications and effects of medications. The youth are really good about reporting on, their moods and anxieties and sleep. Sometimes the youth, and again, you in your office, you may experience that youth may have not shared depression or suicidality with a parent. Excuse me, they may have shared it maybe with a counselor or a teacher who they feel comfortable with. Other areas of inventory and assessing depression are the self-administered scales, and those include the Children's Depression Inventory, the Center of Epidemiological Studies. The CESD is one designed for children, the Beck Depression Index, and also the PHQ-9, and the toolkit that was the guidelines for adolescent depression for primary care. In that toolkit, they have copies and access to all of these assessments that are in the public domain. And so we'll make sure that that's available to you in our website, so you'll have access to those resources. So gathering history. So again, it's important to not kind of forget to think about neglect, abuse, physical or sexual stressors or experiences in that child's life. Domestic violence is profoundly significant and will reflect on how the youth is, even if these activities were experienced only for a short duration, and maybe at an age where you would probably think that the youth would have no cognitive recollection or memory. But it's amazing what 18-month to 24-month-old can experience during situations of violence. Recent stressors, you need to explore anxiety symptoms, unusual thoughts, or psychotic symptoms. Could it be a prodrome to schizophrenia? It could be, based on the family history, but could it be associated with stress, anxiety, or even symptoms associated with profound depression and sadness? Symptoms of a mania are either present or in the past. These are things to explore, especially if you're thinking that the symptoms are severe enough where you're thinking about starting a medication trial. You definitely want to ask the family about experiences with bipolar illness with a family member in the past, or within the youth themselves, if they've had any experiences with a trial of an antidepressant medication and it caused hypomanic or manic symptoms. And those symptoms include, not sleeping for days, hypersexuality, grandiosity. And then also assessing family history of suicides. Genetics, depression definitely is a strong genetic component, runs in families. I think the studies of monozygotic twins being raised together, 76 concordance regarding them sharing depression. Even those twins raised separately had a high concordance of sharing depression at 67%. Children with one depressed parent, 3 times more likely to have major depressive disorder than children with non-depressed parents, and need to ask about family history of bipolar disorder. So this has been repeated a number of times. So when you're thinking about mood lability and mood dysregulation with a youth, you want to spend quite a bit of time exploring mood dysregulation in a family. And we'll talk more about that in the next few slides. And this one in particular, the effects of the depressed parent. And when you're assessing the youth, you really are trying to assess the family and the role of depression within a caregiver. And so lots of studies have shown depressed children tend to have poor relationships with family and friends, but they also often have depressed parents. And depression in parents are associated with child depression, and it's probably more so with the depressed mother, more so than the depressed father. Depressed parents may over-report concerns of negative aspects of the youth, or because of depression, they may under-report concerns because they've not been able to tend to the child. And some of the studies that are looking at treatment interventions for adult depression have shown in the STAR-D study that children's symptoms often improved significantly when mom's symptoms improved and she was treated for depression, especially if her depression was treated successfully within the first 3 months. So lots of things to look at for differential. These are just lists that kind of highlight infectious illnesses, neurologic illnesses that could be associated with the depression in the child. Always really trying to explore the role of flu, even with the COVID-19. We're seeing a lot of our children infected, and whether that's, and we're not even sure if we're seeing the long infection of COVID-19 with our kids, as we are seeing with our adults who talk about cognitive clouding and blunting and having a poor concentration many, many months after the passing of an acute COVID-19 illness. So we talked about infections, neurologic, it's important to rule out any history of epilepsy, but also important to be thinking about head trauma or loss of consciousness. Endocrine.
We have a question back to the genetics.
Mm-hmm.
Are higher rates of depression if mother is depressed because more children may be with mother than father in a single parent family?
Yeah, great question. Yeah, absolutely. So we're looking at both the genetics of the family, but also the genetics of mom being also depressed and her influence on the child's depression, definitely. Sorry, I went so far back. It's going to take me a second to get going. Did that answer your question? And were there any other questions?
I think that answered the question. Yeah.
Okay, great. Endocrine, thinking about diabetes, thyroid and parathyroid function, other areas that could influence and be part of the presentation of mood disorders for children, especially depression, even steroids and the use for asthma and things like that. You want to know as much as you can about that. For the adolescents and some of our older kids, pre-adolescent kids, their experience with alcohol and drug use. Just saw some work done with the role of bupropion and dextromethorphan together in treating resistant depression in adults. But again, our kids have access to cough syrup with significant amounts of dextromethorphan, and they come into the ED very disorganized, delusional, agitated, and psychotic. So what works kind of, for our refractory depression in adults, for our kids in the developing brain, even small amounts of dextromethorphan can cause problems. So think about not only alcohol, drug use, but also over the counter. And dextromethorphan is definitely over the counter, and the kids get access to it and they drink bottles of it at a time. Psychiatric disease and differential. And when you're really thinking about depression, a huge amount of our kids have comorbid pathologies and illnesses. which can include anxiety and the disruptive spectrum of disorders, so like oppositional behavioral disorder, oppositional defiant disorder, and conduct disorder, and the spectrum of ADHD and substance use. It's important that a lot of these are kind of co-associated with your youth presenting with depression. And it's pretty rare that you have a youth with only one illness. Was there a question, Summer?
There is a question. Renata asked, well, comments. There's a newer Coke product that has psychoactive ingredients that can exacerbate mental health issues. So back to the previous.
Did Renata mention what that was?
Renata, do you know what product it is? She says she'll look it up.
Oh, okay. Absolutely. Take your time and we'll address it. Because it's really important, right? I mean, the kids have access to this over the counter. And we're going to talk a little bit, and I hope I have time to talk about some of the safety educational points regarding safety in the home, and also, safety planning, especially when the youth has access, or maybe their own medication is protected or managed by the parents, but a lot of the parents' medication is still in the medicine cabinet where the youth has access to, or other things that they can use to harm themselves, such as, razor blades and things like that. And so usually when we do safety planning with a family, we also want to ensure that that planning is then translated into the school. And so that the counselor and the school behavioral health specialist or support person can also include that for the skill or the safety planning at school, and also for maybe even safety planning in an IEP, if that is part of the youth's constellation of care. And that's when I'm talking about, working within the systems of providers that are working with the family and the youth. Okay, so let me just keep going. So workups include, history and physicals, talking with a primary care physician about how things are going, and getting baseline laboratory exams, making sure that their vaccinations are all current. I used to say for teens, considering based on the history, a urine drug screen, but even in our older preteens or even our older kids, there's quite a bit of experimentation going on in the community. I basically am trying to get a drug screen for everybody, and also other suggested labs here. The course of major depression and for kids, when you're thinking about a duration of an episode, maybe 8 months or so, and then clinically referred youth, 70% of those children will have a recurrent major depressive episode within 5 years. And then almost half, 40%, a strong indication that they could develop a bipolar disorder. So strongly encouraging providers to explore the role of bipolar illness in the family when kind of embarking on treatment for kids for depression during the course of depression. And these are usually the things that we like to share with the educational process of family education and educating the youth, but also educating the teachers maybe, or even in the person who's kind of managing the IEP for the youth, or the 504 plan, when you're talking about a crisis management within the school, or how to help the youth during stressful times. And so prediction of relapse is usually dependent upon the age that youth is first experiencing depressive episodes, the number of previous episodes, severity, and was there psychosis involved with that, and also an element of adherence. And so how well is the youth adhering to treatment planning, whether it's, meeting with the therapist or the therapist coming to their home, the adherence with the medications, is the family involved in providing management over the medications. And at school, when you're working with the school nurse, which is incredibly common, is, how is the youth involved in engaging with the school in receiving their medication, and things like that. And what challenges are there for the youth who has to go to the nurse's office to get a medication? And is there any stigma related to that? Some of the poor prognostic issues, and I'm going to keep going. I will probably not be able to cover all the slides, but again, if we do have an open Tuesday in the future, I can always follow up with the rest of these slides. But in regards to poor prognosis, it's really related to the severity, how serious the symptoms are, how early was it during the developmental phase of that child where they started experiencing depressive episodes, and the chronicity of relapse. Symptoms that are residual, that were not completely resolved, kind of a negative cognitive style or hopelessness, and then psychiatric comorbidity. Comorbidity is what is the number of other additional psychiatric illnesses that are co-presenting with depression. Low socioeconomic status is very significant. Family problems, ongoing negative life events. One thing I haven't mentioned was our children who've experienced food and housing and shelter stability. Some of our children have not experienced safety within school or with housing and food. And so those are also concerns, and those can also be a significant factor to ongoing depression and part of a negative life events. One thing I wanted to say here with the sequelae is depression for the untreated children. The depression will have a profound influence on not only their development, their emotional and cognitive development, but also their engagement and learning skill sets, both interpersonally and personally. For any child who's probably, they come to you and they say, or the family says, we've really been dealing with this for my 7-year-old or so for almost a year. As we learned last week with Dr. Patel, when you're thinking about 9 months for a child, that's a very long time in proportion to that child's age and life compared to an adult. So you don't want to be too slow in engaging that family into treatment. For those who have been not treated, so there's a high risk of access to nicotine or use of cigarettes and substance use, teen pregnancy, other physical illnesses, other infections. And as adults, there's a higher suicide rates, more medical and psychiatric hospitalizations, more impairment in work and family and social life. So it really is important that we address this as early as we can, even as we're seeing a great percentage of our adolescents experiencing depression. But now, even since the pandemic, we're even seeing a greater sense of our adolescent population experiencing profound depression, and also suicidal thoughts that they're exploring more or acting out on more. So treatment includes psychoeducation with both parents and schools, also others that are part of that child's life. Individual psychotherapy could be supportive, CBT or interpersonal psychotherapy, family therapy, and medication. It's nice that see medication on the very bottom. because rarely do you start a medication before you engage all the other things that are above that. Treatment goals. Our treatment goals are to achieve a response as quickly as possible. So where there's a significant reduction in symptoms or no symptoms for 2 weeks. This is also, challenging if you're using medications, because you tend to want to start at a very low dose and increase very gradually and slowly, because children have a higher side effect profile with the medications than our adults do. But as we just saw, that medication is the last thing you're going to do before you start interventions that include education, psychotherapy, family therapy, and many times you see response just from those interventions alone before even the consideration of medication. So that's what's incredible, but that's also what the studies, the clinical trials of using these medications with children for depression in the past is that compared to placebo, so many of the children responded so well just to placebo alone. It complicated the data in comparing the medications to placebo, but it also showed us how responsive the children are to engaging with teams and psychotherapy and those who are making changes in the child's life, such as reducing stressors. The goal of remission is to see at least a period of few or no symptoms for between 2 weeks and 2 months. That's what we call remission. That's probably in many of the studies, you'll see they reached remission. And then recovery is where you see the absence of symptoms for greater than 2 months. So for any treatment, you're really aiming for recovery as your goal. So treatment recommendations, the initial steps, especially if you have a positive screening, especially in primary care, if you have positive screening within the health center, engaging families with services immediately, either within your clinic or your community health center, or thinking about referring if you need to. At Queens Counseling Services, many primary care providers have referred children for additional services there, even services beyond medication treatment. So psychoeducation and treatment planning. And then for mild to moderate symptoms, usually it's engaging the family with services immediately and just monitoring them closely. And I'll talk a little bit about this, about follow-up and frequency of follow-up in a second, and keeping a close eye on them for the next 8 weeks. And then more moderate to severe symptoms, you're starting, evidence-based family therapy, cognitive behavioral therapy, interpersonal therapy, and for the severe presentations, medications. But again, starting immediately with intervention, and that means addressing the context of stress at home. So whether it's family needing additional resources, assessing food and housing security, looking at the element of trauma and stress within the family. Does child welfare services need to be involved? This happens a lot at the emergency room or the family treatment center when children are there. And child welfare services needs to be notified because of significant danger at home. And so just addressing those things immediately could cause and provide profound changes for that youth. And then again, engaging in cognitive behavioral therapies, family therapies. And if you have those resources at your community health center or in your primary care office, we recommend that you engage in those as quickly as possible. But on severe cases, maybe you need additional resources, or you may not be comfortable managing the medications. And that's why I brought up the idea of CAM-HD and the new registration forms that are online. Is many times in the community health centers, having CAMHD as a referral and a partner in the care of the youth really goes a long way when you're trying to engage the systems such as school, family court, and other things within the care of the youth, where it's a little bit more challenging to do it alone if you're at a community health center. Psychoeducation, always important to not only discuss with the youth and the family the course of the illness and how you're going to treat it, but it's also important to bring the school into the discussion. I found it incredibly positive, and the teachers would say, or the special services counselor who was managing the IEP for the youth, they said that, you know, nobody's ever brought us in, never discussed the illness, and especially when you're thinking about safety planning, crisis planning, and, you know, appropriate timeouts for the youth when they're depressed or anxious, a place to go where it's safe, a place to go for them to practice their skills of deep breathing or relaxation outside of the classroom. A lot of the teachers are incredibly motivated to assist with that. What else do we have? Oh, okay. Yep. Families should be meeting frequently to monitor progress. You may not be able to have the family return every single week, but for such as the Queen's Counseling Services, the clinic, even though they maybe schedule a follow-up in a month, within a week or so, somebody's reaching out to the family or the youth or the school and checking in to see how the youth is doing after the starting intervention. So again, this is just a repeat of a previous slide, mild to kind of less moderate symptoms. You're providing initial care and then monitoring that can include family therapy, but more of the higher end of moderate to severe, you really are thinking about a medication trial. And some of the medications, then there are not a lot that are FDA approved for children. There are quite a bit more FDA approved for adults. But the primary family of antidepressant medications is the SSRIs, or the serotonin reuptake inhibitors. There's also the norepinephrine reuptake inhibitors. There are other antidepressants such as, I don't know, bupropion. We talked a little bit about that just a moment ago. With the use of dextromethorphan for refractory depression in adults. Remeron and mirtazapine, bupropion is used for children, but again, there's no FDA approval. Tricyclic antidepressants, of course, are used for children. And we will talk a little bit more about the clinical trials for the use of tricyclic antidepressants for depression. And then again, typical duration, and we're asked this a lot, the duration of the medication treatment, you really want to see 9 to 12 months of complete recovery or response after the initiation of treatment. So you want to see the removal of all symptoms for maybe 9 months to maybe 12 months. And the evidence base for that is you'll see a longer period of time before relapse. And we already know relapse of symptoms of depression are going to occur within those first 5 years. I mean, it's important to expect it. It's also important to prepare for it. And that means maintaining a relationship with your family, even when the medication is stopped. But if relapse is very significant and it's high when you may have stopped that medication within the first 4 months of symptom improvement. And many times that happens when the youth shows up and says, well, I stopped the medication several months ago, and because I was feeling better, or the family said, we let them stop it because we thought they were doing better too. And that kind of really says, it's really important for the provider to engage the family where there is follow-up and there's communication, and there aren't several months that go by without communication with the family, especially when a youth is taking a medication. All right, and let's see here. All right, so some of the medications, and as I mentioned, first line is usually the SSRIs. Fluoxetine is FDA approved for our children from 8 years, at 8 years old. We use the second, usually we try Prozac first. Sertraline or Zoloft, which also indicated for depression in children and adolescents, and also Lexapro. And the clinical indication or the FDA approval for Lexapro is age 12, and then Luvox. Again, when it comes to adult depression, there are a lot more medications that are FDA approved. So we talked a little bit about the early studies with a huge placebo response. And so a lot of the clinical trials and the randomized control trials had to take that into effect. And so many times they had to wait for a period of time. And then kind of the first set of studies were in the late 1990s when fluoxetine was studied with children and saw a response rate of close to 60%, but also a response rate of placebo over 30%, which is pretty significant. And then follow-up studies in the early 2000s with a randomized controlled trial of over 200 youth showed of 20 milligrams of fluoxetine showed a remission of symptoms of 41% and placebo at 20%. In regards to the further clinical trials, I think the one that's probably most significant is the TAD study, and that's a treatment of adolescents with depression. And that was looking at over 400 adolescents with severe depression. This was a four-arm study, and that means there's a group of those 400 kids that received only the fluoxetine or Prozac, a group that received only CBT or the psychotherapy, and the group that received placebo alone. And then there was a group that received the fluoxetine and CBT together. So of the four groups, then you see the distribution of outcomes. And probably the group that responded the best was the one that received both the medication and the psychotherapy together.
I have a couple questions.
Yep, sure.
So if a patient initially responded well and then relapsed while on meds and meds subsequently were increased, is time restarted, or is time to monitor until meds can be removed from the new dose changed?
Yeah, great question. So you really start sensing or seeing the role of medication and titration, and that window is all the same. So you start your time of stability is when one is you may not be making any changes to the medicine for a little bit, but are the symptoms resolved? Is there recovery? Is there a response? And then is there remission? And is there a greater than a 2-month window where there are no symptoms? And it's at that period, within that 2 months, I start the countdown. And I'll start, and I'm aiming, and I'll let the family know, and I'll let the school know that we're really shooting for 9 to 12 months from this period, even though we've had to make multiple changes. And we may need to make more changes going on, because a lot of the kids will experience stressors throughout the year where you have to make medication changes with. They may be living with a new family, especially if they're with child welfare services. They may experience this a lot where they run away, and so they're out with and they're homeless, and then you have to think about restarting medication, and then does the timeline start from there or other things? So there's a lot that goes into your discussion with the family and how long you want to have it. But again, The studies show that though, if you stop your medication with, earlier than 4 months of treatment, because, everybody says that they're doing great, they don't need the medicine anymore. The studies really do support that relapse is profoundly significant because of that. And you can delay that relapse quite significantly if you can maintain medication for the child for that 9 to 12 month period. I hope that wasn't too confusing. I'm so sorry.
A question to follow up with that. So do they ever outgrow it, or are they on meds for their whole lives?
Yeah, great question. So we always help our families understand that we are really looking at that 9 to 12 month period of symptom free. And then we start thinking about tapering off medication. But when you're talking about tapering off medication, you're talking about also the youth's life and the things that they're going to be experiencing going forward. So what is school like? And are we managing all the stressors at school? What are the interpersonal challenges that the youth has with bullying or other types of things that can cause significant susceptibility to mood dysregulation and these impulsive thoughts of wanting to hurt themselves because of a stressor at school? Are we managing those things well enough? And that's why when you're thinking about working within a system, you really are trying to engage the school and the family and the youth as one system working together to put structural boundaries around that child to make sure that they're being protected by all those stressors that they're exposed to. But it means that we're also training them with their skills, their cognitive behavioral skill sets, their interpersonal skill sets that they're learning to engage in life and to be able to manage those stressors and grow from those stressors rather than to regress and to, to regress and do poorly with those stressors.
Thank you.
Any other questions?
That seems to be all in the chat. And Renata touched back on that Coke product. She said she thinks it's Coke Energy with guarana that could be triggering the psychoactive ingredients that could be exacerbating the mental health issues.
Well, that is so interesting. Is anybody in the group familiar with that? Have they seen anything?
Feel free to unmute yourselves also at any time. Nothing in the chat.
Okay. So it's, there's 4 minutes. So I'm going to just keep going and maybe for a minute or two, and then I will make sure that this is all posted for others to have access to. Let me set this up for, oops, and we'll do this. Okay. Okay. I will talk a little bit about the Tordia study. The Tordia study sounds odd, but this is one of the first studies to look at treatment-resistant depression for children, as there are studies that look at treatment-resistant depression for adults. And what I did want to say in the few minutes that we have is that we're very fortunate to have the Kahala Clinic team join us again next week, looking at sleep apnea and the role it might have in refractory depression in children and adults. And so that's something for next week, and we will learn a lot because that whole team is incredible. And I mean, they're just specialists in looking at that and the role of sleep. We are also fortunate that I believe Dr. Ona will be speaking more to us in the future, in the very near future, and the role of transcranial magnetic stimulation and its role into refractory depression in our adults. So when we're thinking about medication trials that are not completely beneficial for our adults, we're looking at the role of sleep and obstructive sleep apnea and devices to help with airflow and also oxygenation. But we're also looking at neuromodulation where electrical stimulation to the brain has also provided profound benefit for those adults with refractory or depression that's not responding to all the medication trials, as well as obsessive compulsive disorder, which had the FDA approval in 2018 for transcranial magnetic stimulation. So the Tordia slide that I just had here was just looking at the role of refractory depression in kids. And again, they did a study of 300 kids, and they looked at the role of CBT and the medication change out of an SSRI into like something like the Effexor or venlafaxine. Didn't really see any significant change, but it also highlighted the importance of having CBT with medications at all times or other psychotherapies. So we have 1 minute. We already talked about TMS. We'll get a presentation on that. There are FDA studies right now, sponsored studies looking at the role of TMS in youth. Right now, the only thing that's neuromodulation that's FDA approved for children in refractory depression and suicidality is ECT. But the TMS studies have been federally funded. They're looking at multiple sites, and we're hoping to have some indication from the FDA if TMS can be considered for our children who are not responding to the medications. So it's 1 o'clock. I want to just say thank you to everybody, but also if you have any questions that I can address before you go, or you can email Summer, we can address those things. And I'm going to put all these resources up in the website for ECHO.